And with this, I would like to introduce our next speaker, Dr. Anand Vaidya. Thank you.
I'm going to pick up where Dr. Bankos left off with dynamic testing in patients who are either tapering or stopping glucocorticoid therapy. Recommendation 2.8, we suggest against routinely performing a dynamic test, which is really referring to mostly a cosentropin stimulation test for diagnosing adrenal insufficiency in patients who are tapering or stopping glucocorticoid therapy. So what is the basis for this? We believe that in the process of tapering glucocorticoids, a simple measurement, a morning cortisol measurement from the circulation, can serve as a fairly easy approach to assess the entire hypothalamic pituitary adrenal axis, obviating the need for more dynamic testing that require resources like rooms, nurses, injections, and so forth. However, if the result of morning tests are not adjudicated or not clear, and your results remain in the indeterminate range, as Dr. Bankos just reviewed with you, in the 5 to 10 microgram per deciliter or approximately 150 to 300 nanomole per liter range, then you can consider a variety of options, including dynamic testing. And the use of dynamic testing, like a cosentropin stimulation test, really requires the clinical context, your particular suspicion and concern, but also the availability of the cosentropin, the room and ways to administer it, the cost and accessibility of these procedures, which varies not only country to country, but even regions within a specific country. So I'm going to highlight a case that reviews this. This is a 53-year-old patient of mine. She was treated with several long courses of prednisone up to 60 milligrams a day on and off for approximately 1 year after she developed ITP, idiopathic thrombocytopenic purpura. And she is now being referred to endocrinology a year later to assist with tapering the glucocorticoid. It's no longer needed. The idiopathic thrombocytopenic purpura is well controlled. So here's a graph of where she lies. On the y-axis are cortisol in blue and ACTH in orange. And she's coming to see us, and her morning cortisol and morning ACTH are very, very low, undetectable or at the lower limit of the reference range, suggesting glucocorticoid-induced adrenal insufficiency, as you would suspect. So this patient was tapered from prednisone 60 milligrams down to prednisone 10 milligrams over 6 months. Her cortisol and ACTH still remained low. And as you saw in the previous cases, probably Dr. Bankos would have continued tapering on prednisone. Stylistically, I switched her to hydrocortisone 15 and 5. I think many of you had chosen that option. And as you see, after she came down on the dosing of hydrocortisone, the ACTH started to rise and the cortisol rose in parallel. The hydrocortisone was gradually weaned, and you can see that the ACTH levels have risen well above the upper limit of the reference range. They're in a supraphysiologic range. And as a result of that, the cortisol has come into what we would call a normal or appropriate range, well above 10 micrograms per deciliter. Her hydrocortisone was weaned and ultimately was stopped. And what you see is the ACTH went from a supraphysiologic back down into the reference range, while cortisol stayed in the appropriate range. So this actually is almost a perfect representation of figure 1 that is in the guidelines that was just shown to you a couple of slides ago. Again, here is the real data from the patient as she was tapered from a supraphysiologic dose of glucocorticoids down to completely off. You see the ACTH and cortisol levels in this figure are suppressed. The ACTH rose to a supraphysiologic level to bring the cortisol up. And right here, what you're actually witnessing is an endogenous ACTH stimulation test. Right? So could you use an exogenous ACTH test, a cosentropin stimulation test, to get a dynamic assessment of the HPA axis? Absolutely. But in the process of this tapering, you're actually inducing an endogenous stim to regain zona fasciculata cells and adrenal function. So for this reason, dynamic testing is usually superfluous and can be substituted with well-done morning basal cortisol and ACTHs at least 24 hours after the last glucocorticoid dose. And again, the interpretation is as shown here. The higher the morning cortisol level, the more reassurance you can have that the HPA axis has normalized. The lower it is, the more concern there is. And then there's this intermediate gray area in between, where if you're not convinced the HPA axis is completely normal or appropriately functioning, you can just continue the taper more slowly. Again, it still doesn't require a dynamic test, but if this process has been going on for a very long time and you're concerned, this is the few instances that you can uncommonly consider the use of a dynamic test. Other clinical scenarios requiring awareness of possible glucocorticoid-induced adrenal insufficiency. Recommendation 2.9, we suggest awareness of possible glucocorticoid-induced adrenal insufficiency in patients, 1, with current or recent use of non-oral glucocorticoid formulations who are presenting with signs and symptoms indicative of adrenal insufficiency, or number 2, who are using multiple glucocorticoid formulations at the same time, or number 3, using high-dose inhaled or topical glucocorticoids, or number 4, are using inhaled or topical glucocorticoids for over 1 year, or number 5, who received intra-articular joint injections of glucocorticoids in the previous 2 months, or number 6, who are also receiving treatment with strong CYP3A4 inhibitors. Okay, so it's a lot of terms there, but basically you can see other areas where you should be concerned are when someone is using one or multiple non-oral formulations of glucocorticoids at high doses, at long durations, or are using a treatment that inhibits the metabolism or potentiates the half-life of these glucocorticoids. Here's a case that illustrates this point. This is a 40-year-old patient of mine who was referred because in the process of complaining of generalized fatigue, someone checked a morning cortisol and it was low. When asked, she actually says, no, I do not take steroids. She doesn't have any physical stigmata of Cushing's syndrome. A pituitary MRI is normal. She doesn't have any masses, lesions, or hypophysitis that are visible. But when you ask her in more detail, actually, she does take an inhaler. She uses an inhaler for what is some vague diagnosis of asthma, and she's been doing this for over 10 years. And the specific dose she's taking includes inhaled fluticasone, 220 micrograms, 2 puffs twice daily. So this is up to 880 micrograms per day, which is a fairly large dose of fluticasone, even though it's inhaled. So this is a very straightforward question for you, which is, can inhaled glucocorticoids, as this patient is taking, and fluticasone for asthma, induce adrenal insufficiency? Yes or no? So hopefully this won't be too difficult of a choice. Just put in your answers and then we can view the final answer. I'm not sure I can control it, so. Okay, very good. So the vast majority of you said yes, which is the correct answer. And though it is obvious, I think it is often underappreciated. So here's some data. Here in this column is placebo, inhaled placebo, with the y-axis showing you the post-inhalation 8-hour cortisol concentration. You can see inhaled budesonide reduces the cortisol distribution, and inhaled fluticasone propionate, which is what this patient is taking, also reduces the post-inhaled cortisol level. And you can see the dose dependency of that. The higher the inhaled fluticasone dose, the lower the post-inhaled cortisol level. And you can see in these highest doses, 1,000 micrograms twice daily, many of these patients have frank adrenal insufficiency. Now, what you notice about this is, the simple answer is absolutely, inhaled fluticasone can cause adrenal insufficiency. But there's tremendous inter-individual variability. For some patients are relatively impervious to this. Some patients are more susceptible to this. Now, whether this is a susceptibility issue, a variable absorption issue, or other factors is hard to say, but the integrated effect is this can absolutely happen. Here's a very large study in actual asthma patients from 2 very large cohorts that validated the same finding, which is when you do detailed steroid metabolomics, you find that all ACTH-dependent adrenal corticosteroids, cortisol and its metabolites, are lower in patients who are on inhaled glucocorticoids, suggesting there is widespread absorption of inhaled glucocorticoids. And this might be due to the absorption effect through the oral and nasal mucosa, but also many patients don't use inhaled glucocorticoids correctly. They don't have a proper spacer or right technique and end up swallowing a lot of the glucocorticoids. So much of this fluticasone can actually be taken orally, even though it was intended to be inhaled. So here is this patient. She came to see me. Her cortisol and ACTH are flat, completely suppressed. I first reached out to the pulmonologist and I said, why is this patient on 880 micrograms of fluticasone? Do they actually have asthma? And we both scratched our head and said, she may not even need to be on this. It wasn't even clear whether her asthma was active or needed treatment. So I worked with the pulmonologist to first wean down the inhaled glucocorticoids. And after weaning them down, she didn't have active asthma, so she stayed off of them. In the meantime, I put her on a safety net, a tiny dose of hydrocortisone, because I wasn't sure what her HP axis would be like once the fluticasone was removed. It has a variable half-life, and we don't routinely measure its levels in circulation. Thereafter, you see that her ACTH and cortisol rose, the ACTH into the supraphysiologic range and the cortisol back into the normal or appropriate range, at which point all glucocorticoids were stopped. And you can see this, the ACTH went from the supraphysiologic level down to the reference range, and the cortisol remained normal. So you see a normalization of the HP axis. This whole process actually in this patient took a long time, a couple of years. And this wasn't necessarily due to biologic effects. It was due in part due to patient follow-up. A little bit of glucocorticoid withdrawal syndrome may have been mixed in there, but in my opinion, months to years is not an unreasonable time frame when these can realistically play out, even though biologically this could have probably been done more quickly. Again, you see a recapitulation of this idealized figure that's in the guidelines where both ACTH and cortisol start suppressed. The ACTH rises often into the supraphysiologic range to cause an endogenous ACTH stimulation test, reviving the zona fasciculata and normal cortisol production, and then both of them go back into their reference ranges and diurnal patterns. Other clinical scenarios that require you to be aware of possible glucocorticoid-induced adrenal insufficiency. So glucocorticoid-induced adrenal insufficiency can occur with any glucocorticoid formulation. There are some studies that try to compare the effect of intra-articular dosing, topical dosing, inhaled, intranasal, et cetera. They're not very good studies that can give us effect estimates that are worth quoting. So what we've emphasized is you just got to use your clinical judgment. The higher the dose, the longer the duration, the greater the exposure, the higher the risk of adrenal insufficiency. And if somebody's using multiple glucocorticoids from different routes, the risk goes up even more. So patients who are receiving topical, inhaled, and intra-articular injections are at higher risk than somebody who's taking just a single inhaler. The other point that I made earlier is that glucocorticoids, almost all of them, are metabolized by CYP3A4. And there are several CYP3A4 inhibitors that are out there, and these can actually potentiate glucocorticoid effects, half-life, and therefore total potency. So the main ones to be aware of are grapefruit juice, some antibiotics, antifungals in particular, and then protease inhibitors. So the protease inhibitor that's most widely used is ritonavir. This is often used as a CYP3A4 booster for other protease inhibitors in HIV care, to a lesser degree in hepatitis C antiviral care. But most recently, it was one of the active ingredients in the medication branded as Paxlovid that was used for COVID-19 infection. And if you practice in the United States, Paxlovid was prescribed quite heavily for the last 4 years, and it contained ritonavir, which boosts glucocorticoids and caused a lot of issues for patients who are on any formulation of glucocorticoid. Manifestations of exogenous Cushing syndrome and glucocorticoid-induced adrenal insufficiency. Recommendation 2.10, we suggest that patients with current or previous glucocorticoid treatment who present with signs and symptoms of exogenous Cushing syndrome are automatically assumed to have adrenal insufficiency. And this is not something I'm going to belabor. If you're not an endocrinologist, we actually do have a table of the signs and symptoms of Cushing syndrome. But for those of you who are endocrinologists, you know that if a patient actually develops physical stigmata of Cushing syndrome while on glucocorticoids, the probability that they have hypothalamic and pituitary suppression of the HP axis is probably 100%, and that can just be assumed. And finally, a lot of this guideline is designed to help non-endocrinologists who prescribe the glucocorticoids deal with tapering the glucocorticoids and helping their patients or shepherding them off the glucocorticoids. But when should an endocrinologist be consulted and a patient referred? So recommendation 2.11 says that what we suggest that patients who are aiming to discontinue glucocorticoids, but who still don't have recovery of their HP axis after 1 year while on a physiologic daily dose equivalent, should be referred to an endocrinologist. And we suggest that patients on glucocorticoids and a history of adrenal crisis should also be evaluated by an endocrinology specialist. So if the disease that the glucocorticoids were designed to treat has abated, If you have tried your best to taper the patient down to physiologic ranges, but you can't go below the physiologic range, either due to what appears to be glucocorticoid withdrawal syndrome or recurrent adrenal crises, these are patients that should be sent to the endocrinologist. Now, keep in mind that endocrinologists, as you've seen in this presentation, don't have any specific or special weapons, special diagnostic tests or tools to accelerate this process. So it might require just a little bit more experience and patience. That's probably the most likely scenario. But occasionally, patients can have more than one problem. They might have a separate pituitary disorder that's causing a lack of restoration of normal physiologic ACTH, and an endocrinologist can think about these problems after about a year. And the final recommendation I'll review is 2.12, which is that we recommend against the use of fludrocortisone in patients with glucocorticoid-induced adrenal insufficiency. So this is a disorder of ACTH suppression by exogenous glucocorticoids. Since cortisol is 100% dependent on ACTH, lack of ACTH results in cortisol deficiency. However, aldosterone is not the same. It is only partially dependent on ACTH, and even in the absence of ACTH, aldosterone physiology will be maintained through extracellular potassium and the renin-angiotensin II system, as well as other factors. So fludrocortisone is not required for patients with glucocorticoid-induced adrenal insufficiency.